Yeah.
Yeah, we
So,
are
good
live,
evening,
madam.
everyone.
Hmm.
So today we are talking about much needed topic on prevention of recurrence using ELAGOLIX. Whether ELAGOLIX is that molecule which we all can use when we are talking about recurrence in endometriosis, which is a very genuine concern from many fertility specialists and also gynecologists who are treating endometriosis day in and day out. So surgery may not be the endpoint or a permanent cure for this problem, as we all know. The recurrence is really very bothersome for both the gynecologist and to the patient, and we don't know in which patient the recurrence is going to happen. So we have a variety of molecules ranging from GnRH agonists to GnRH antagonists, which are now available across, I think, the globe. Even for some time, we were using progesterone, either intrauterine devices or oral progesterone, injectable progesterone to prevent the recurrence. So right now, the molecule which is a favorite of so many people is the Elagolix, which is a GnRH antagonist. And this drug has been used, abused, misused. And this we will discuss today about whether it is a suitable drug for preventing the recurrence of endometriosis after the surgery. So we are not discussing about use of Elagolix primarily, though in many groups we had these queries today about use of Alagolics in young girls, and we were like thinking that we should have another session on that altogether. Today's session we will focus only on the recurrence rate, whether it can come down with the Alagolics or whether it is a suitable one. What are the problems that we may come across when we use, and what is the dosage? Also, what is the time period that we can use this molecule for? From Dr. J. Yeah. You can start, please.
Okay, guys, welcome. I would also like to welcome all the patients who have joined in for today's masterclass because I believe from here onwards we'll be having a lot of patients joining in also. As you all know, today is day 2 of Navratri, and that is why Shilpa madam or goddess Shilpa is dressed in a red colored sari, as you can see. So, to all the people who are yet to follow her, please follow her on Instagram and Facebook because tomorrow there'll be a new sari coming in. All right. But irrespective of the number of saris which Shilpa madam will keep on changing, the problem is Elagolics and Dynogest people are not changing. Actually, they should stop using Dynogest and Elagolics and change to things which are better. So we must understand one thing. Elagolics has no proven study because these days, if you are a patient or if you are a healthcare provider, the first thing which we are worried about is practicing, at least practicing on paper, evidence-based medicine. And by mistake, if in case we want to practice evidence-based medicine, there is absolutely no long-term data available for post-endometriosis surgical recurrence, which is managed by Elagolics, okay, which is a GnRH antagonist. So you have no data which is available. That is the first thing. The second thing, the drug has only been introduced for temporary management of pain, irrespective of the size or location of the type of endometriosis which it is. For an Indian population, the standard dosaging which you should be using is 200 milligram twice in a day. And fortunately, even the manufacturer has recommended that drug should not be used for more than an interval of 6 months. The max you can use it is 6 months. So keep that in mind. You should never ever forget to counsel the patient about the most common complication with this, and that is permanent and irreversible osteoporosis along with severe hair fall along with severe mood swings. These three things or four things is something which probably you should take down in writing, just in case you are somebody who is destined to abuse this molecule. Now, why should you not use it in a post endometriosis situation? Now, the first thing, as far as you know, Dr. Shilpa really mentioned that very nicely, that even if the surgery is done, we need to make sure that in order to reduce the recurrence, we need to give something which is going to take care of the management, right? So where does the recurrence occur most commonly from? Majority of the times the recurrence either occurs from the ovary or occurs from the peritoneum. These are the two things which you should remember. Any deep nodule which you remove completely with wide local margins, you are not going to expect any recurrence coming from that deep nodules. Just keep that in mind. You need to remove the nodule with a wide local margin. That is the rule. You can't see a nodule and keep it there. Okay. If in case you say that I did not open the pouch of Douglas, that means you have done an incomplete surgery. In an incomplete surgery, there is no role of giving post-surgical management. First, you need to do complete surgery, and after you do complete surgery, you can give patient a post-surgical management. We have discussed this very beautifully in our master classes before, that endometriosis is a disease where there is estrogen dominance, but this is altered estrogen. Simultaneously, there is a lot of progesterone resistance. And as a result of this, the molecule is such, the tissue is such that it starts to produce its own estrogen. It is like an atmanirbhar situation inside. Understanding? And when there is an atmanirbhar situation inside, till you do not go and remove that chunk of the tissue, you are not going to benefit the patient by giving medical management. So the first thing to treat a post-operative case is basically make sure that the surgery is complete. That means no disease is remaining inside. Once you do that, you can give the patient the most scientifically proven post-surgical management, that is injections of GnRH agonist or long-term management with oral contraceptive pills. Countless studies have been published on this, and countless studies have consistently proven that it is safe. Studies have also been published for Dynogest, which can be easily given to the patients minimum for a period of 9 to 12 months after the surgery, but provided the surgery has been done completely. That means all the disease has been removed. For all of you, if you are a healthcare provider, irrespective of what the marketing the company is going to come to you and do, be very, very vigilant before providing this drug over a long term horizon to the patient. Because recently, and I have posted it multiple times on social media as well, what we have started seeing is that a lot of these young girls who are on ELAGOLIX are coming to us with severe amount of hair fall. And when we are operating these girls, okay, there is a severe amount of vascularity which is seen close to the nodules. Be super careful of these types of situations which you may encounter in your practice. One more thing, please make sure that you do not get carried away by any of the marketing which happens, because remember guys, the marketing is specific. I have never had a representative of Elagolics come to meet me, never. That is because they know that they will not stand a chance in front of me. They are going to come, and specifically the company has given them specific directives to go and market this drug to people who don't operate. Okay, irrespective of what we say, company has all the data of who operates and who doesn't operate, and who think they operate, who calls whom to operate. Every data is available with them, and they have a beautiful marketing network to go and pinpoint it to those guys who don't operate and promote this drug inside your system. Do not let that happen to you. Ultimately, it is not going to do any good to you or your practice or your patients. Okay, one more thing I wanted to add before I finish. This premise that an oral GnRH analog, okay, guys, trust me, if it was so good, no, it would have got the importance of like how Dynogest or Zoladex or somebody has got, right? Globally, it would have become a phenomenal drug. But if you see, people genuinely don't talk much about it. The reason why they don't talk much about it is because even for people who have started using it in their practice for management of endometriosis pain pre-surgically, we will see people in India 25 centimeter endometriosis, people don't know how to operate, they don't want to refer. Okay, so what they will do, they'll give elagolics, but the pain management is also not so good. Only around 60 or 50% of the patients actually benefit from any pain management as far as this drug is concerned. So be very careful. It may or may not live up to its expectations. It may be something which should be severely restricted and restrained as far as usage is concerned, should not be the primary line of management, even if it is pre-surgical or post-surgical. And the take-home point should be do a complete surgery, and if you require, then either give oral contraceptive pills or give an injection of Zoladex or whatever you are comfortable giving, but do not switch to giving elagolics in a post-surgical recurrence situation under any stretch of imaginations. With this, I will finish my 10 minutes. We can answer maybe two or three questions from Shilpa madam.
So, what are the choices of oral contraceptive pills that you prefer?
Anybody. Anybody is okay.
What about the progesterone only pills
It's
like,
fine. Dynogest is the progesterone only pill.
yeah. What about,
Even Dufaston is fine, man.
okay, what about Novex, Cevista?
I have no experience, man.
You don't use that very often.
No. I have
What
zero
about
experience of using Sevista in practice.
the progesterone containing intrauterine devices?
No, I'm not a big fan of putting Mirena because you have a lot of these girls who are young, unmarried, and want to have children. So I don't like to put Mirena inside them, madam.
Okay. So if it is not for fertility purpose, say when we are talking about surgery, like nowadays we see a lot of women above 40 who are coming with severe endometriosis. So in such cases where you operate,
Yeah.
okay, like you have done clearance of say TLH, BSO, everything like
After
parametrectomy,
TLH,
all
BSO,
this.
nothing is needed.
Yeah. Okay. So, okay. So you don't advise anything post TLH,
Nothing.
BSO?
Nothing.
Okay. So that is in case if the complete clearance is done in that surgery.
All this is, it's like reproductive immunology. All this is if you have euploid embryo. Same manner, all this is if you have complete clearance done. Half clearance, nothing.
Okay. And in such situations, like, in young girls who are desirous of fertility and who come to you for surgery and post surgery, I have seen you give Zoladex most of the times
One
and they
shot.
are
Correct.
amenorrheic for more than like 3 months. So, in such situations who are not affordable for Zoladex, so then we kind of like, compromise and give them contraceptive pills for
Yeah.
3 or 4 months. So in such cases, like you must be having a follow-up of quite a few cases now.
Yeah.
So of course, like the GnRH agonist long-term, the depot is much superior than contraceptive pills probably. But
Only
what is
problem
your
with contraceptives, no, madam, is breakthrough bleeding.
breakthrough
Many a
bleeding? Yeah.
time, these girls, if they forget to take one dose or don't take it correctly on time, no, they will
Mm.
bleed for 7 to 10 days in between, madam. That is very frustrating for them.
So you tell me, I mean, what is your recurrence rate in your practice in these people who are desirous of fertility who have been operated by you?
Madam, my data might not be the best data because my volumes are huge and my rate of recurrence is very, very less. And one of the reasons why my rate of recurrence, like we are going to publish this, right, with Sanchari, almost 10,000 cases of endometriosis, rate of recurrence in 10,000 cases is 0.17%. But I don't think that is to be calculated because we are very, very radical, madam, when it comes to disease excision. No, we end up removing the disease from almost everywhere. Even when places would be where people will think, nahi, nahi, we'll just leave it. We don't do that, no. So I
Mm.
don't think we are standards for that. But I personally think that if you do a good surgery, then definitely you will benefit the patient at this moment because at this moment there is no other alternative to doing it.
So tell me this. I mean, I'm just asking this. I mean, not keeping you in mind. So for an average surgeon, for an
Why do you not keep
average
me in mind?
I don't want to. So, for an average endoscopic surgeon, okay. So, doing endometriosis surgery is again an advanced level of endoscopic surgeries, and everybody might not have that kind of competence to do the kind of radical things that you do. So, in such situations, you think like, the recurrence rate definitely will go down by giving this kind of suppression for a
No,
couple of months, or do
no.
you think there is no substitute for a good surgery? I mean, can this be a substitute? Is what my question
No,
is.
this cannot be a substitute for a partial surgery. The reason why I'm calling a surgery a partial surgery, I'll just give you an example, madam. We've had like so many situations where people have really operated nicely. But you know what they've forgotten to operate? There was a plaque on the intestine. They thought it is just a plaque. They did not go in and operate it. They did not do, let's say, a deep rectal shaving or a discoid excision. They did not use intraoperative ultrasound. They did not use the ICG dye, whatever. I don't want to get into what they did not do. And the disease has come back at the same place,
Mm.
right? So till you do not do that extra care for your patient, you cannot give these types of drugs and then say, oh, I did an almost complete surgery. And now after an almost complete surgery, I've had a recurrence despite using the drug. The problem is the word almost. Okay. And
Mm,
the problem
mm,
is in you. You should have not done an almost complete surgery. You should have done a complete surgery. That is the
mm.
problem.
Do you think the same thing holds good even in TLHBSO, where we kind of leave out a little bit of areas
The
where there is
tis-
an.
the endometriotic lesions are resistant to these hormones which are produced by the ovary
Mm,
because they are in an environment, micro environment, where they are producing their own hormones. They are
mm,
atmanirbhar, madam. Even if
mm,
you remove the ovary and you leave a bowel disease behind, you
mm,
and me have both seen occlusions, correct?
mm, mm,
So
mm,
the disease will keep on growing. There is no
mm.
shortcut to this, ma'am.
So in the past, 1 year, have you seen an increased incidence in endometriosis at all?
No, I'm
It's the
operating
same.
almost the same numbers,
Same
ma'am.
numbers, no? Okay, you
Yeah,
should work hard. Okay, yeah.
yeah,
Okay, thank you so much, everyone. Thank you for joining. So there are one or two questions. I'm sorry, I will
yeah.
just ask this. So if the patient is on Elagolix, should we wait for some time to reduce vascularity before
No,
surgery?
no, no, no. If the patient is on elagolics, please make sure that you operate the patient next day morning.
So today, trying post-surgery, okay, no medical treatment. Where you can't do TLH, BSO, so uh, there are,
It's
okay.
simply not possible. Uh,
Um,
it's simply not possible. If you cannot do TLH with BSO, that does not mean that the disease has to recur. Just remove endometriosis from everywhere, keep the uterus, ovary, and fallopian tube behind. That is the standard practice for 90% of the patients.
So tell me this thing, like a lot of adolescents now, unmarried girls are coming with severe endometriosis and
Yeah,
pain. So they ask, whether it is better to get the surgery done now, or whether it is better to get the surgery done just before marriage. And they're not like so much in pain or symptomatically so bad. So what would your advice be? I know, you are a good surgeon. You want to, make them symptom free as early as possible and all those things. But practically speaking, the post that you had posted today on Instagram
yeah,
about the gender inequality and how girls, they don't have that kind of freedom to choose when they want to undergo the surgery, considering all the social factors
yeah,
also. So, I know, you tend to just deal with the problem, okay?
yeah,
But with all these frills around and with all these lateral things happening, so
yeah.
what would your advice be?
My advice is still always going to be the same, ma'am. I am not going to be deciding on an advice based on the social circumstance of the patient. The
Arey, how
patient,
can you say that? That is wrong. I mean, see, you may be the greatest of the endometriosis surgeon, but see, when we discuss the patient as a whole, we need to see, because the patient is going to stay with us for the rest of her
yeah,
reproductive life.
correct,
And it is not about losing the patient. You need to understand this. This is not about losing the patient to somebody else or pushing the patient either to agree to our management or not. It is about giving a consideration into her situation, circumstance, and also, the best possible treatment that
correct,
we can offer.
correct. So if
So,
surgery is indicated, we have to write down that surgery is indicated. It's
so how
very, very
far can
simple.
we push it? See, now we discussed about post-operative recurrence. So similarly, pre-operative, can we push the surgery for some months or for some
Not if the patient is
weeks?
having any sort of a deep endometriotic lesion. For example, if the patient is having, let's say, a bowel infiltrative lesion,
Mm,
a
mm,
lesion infiltrating onto into the kidney, a
mm,
lesion infiltrating in the ureter, all
mm.
these things you cannot push.
Yeah, yeah.
If the patient is having just endometriosis, that means the
Mm,
patient is having only ovarian endometriosis.
mm,
Correct?
mm,
No.
mm. Yeah.
4 centimeter, 5 centimeter. And if the mapping report has turned out to be negative for deep
Mm,
endometriosis,
mm, mm.
then maybe we can allow her to wait a little while, get socially stable, finish off her exams,
Correct.
something
Yes.
like that. If at all
Yes.
there is something,
Yes.
if at all there is some situation like that,
Mm,
and in
mm,
that meanwhile we can give her oral contraceptive pills. Let's assume
mm,
for that window.
mm, mm, mm,
But in any case where there is deep endometriosis, I'll just give you an example of somebody whom we operated today. We operated this girl in whom she was told that she is having ureteric endometriosis. Of course, she is a doctor herself, so she came in from Punjab. She got operated, everything done, no problem. But along with that, madam, she is also having sciatic root endometriosis. Correct? Let's assume it if she would have delayed it, she was already delaying it for 2 years. Now let's assume if she would have taken the third year also, something would have happened to the nerves, no?
See, they will be in terrible pain. When you're
Yeah,
talking about ureteric endometriosis, then there is parametrial involvement, and that is why there is compression of the ureter. If you're
correct.
talking about, nerve involvement, definitely, how we have treated all the
Yeah.
deep peroneal nerve and all, so many things,
But as I told you, if there is no deep endometriosis, if
Hmm,
the size of the lesion in the ovary is usually less than 4 centimeters or so, you
hmm,
can wait a while, give oral contraceptive pills to these girls, let's say till they finish off their exams or whatever they have to do. And
hmm.
ultimately, they will have to do an excision surgery, madam,
Yeah,
at the
yeah,
end of it.
yeah, yeah.
The only criteria where you can switch from excision to ablation is
Hmm,
if the AMH is very low, the
hmm,
girl is already married, the
hmm,
cyst is around 4 centimeters, let's say lesser than 4
hmm,
centimeters in size, and she wants to do an IVF egg pickup, ma'am.
hmm.
That is when you do an alcohol ablation to the patient, immediately stimulate her in the next cycle, and then you can take the fertility journey forward.
Yeah.
But otherwise, apart from that, excision is the treatment of choice.
Correct, correct. Okay. Thank you so much. It was wonderful. I think these were few of the practical insights. I think many people keep asking us in our groups as to how to manage and the recurrence
I
especially.
just wanted to answer one question which somebody has asked, and I think it's a very, very probably not a question to be asked, but I'm still going to answer this. People always have this thing that is MRI mandatory, okay, for detection of all endometriosis cases. So guys, remember, it is not the MRI, it is the person who is reporting the MRI which really matters as far as endometriosis is concerned. Now, just in case you are one of those guys who simply cannot survive without an MRI, then the best MRI you should be doing is a gel contrast MRI with a gel contrast put in the vagina and the rectum both. All right. Let's assume you are trained in ultrasound and you have a good ultrasound machine. Then then the method of diagnosis for endometriosis is by doing a good ultrasound. A good ultrasound helps you diagnose everything. It is called as endometriosis mapping. Okay. So I think that is something which I just wanted to drive home. Thank you so much.